Okay, everybody. Today's topic is medicine and race. We were focusing more on class and race and economics in the previous lecture. And today's readings really highlight disparities that fall along race and how that actually plays out on the individual level for clinicians and for patients. And for those who've taken HCS 100 or other classes that may have introduced some of the terrible tragedies of medicine and race in this country. There's a long legacy of racism in healthcare, institutional racism, individual racism, the Tuskegee experiment led by the government that Clinton ultimately apologized for. And then most recently, what we're seeing, of course, is the COVID-19, who is contracting the disease and who's dying from it. And it's not a cross section of the United States, not even close. It's falling the hardest on people of color, African Americans and Latinos, way more than their proportion of the population. And so, this new deaths of despair phenomenon has a new twist on it with COVID-19, that it's hitting people who can't hunker down at home, who can't work from home and make a living, and have to go out and have to earn a living, and putting themselves at risk. And many of these people live intergenerationally, so the risk is also greater for older people because younger people who are working in the household are coming and going and exposing them. And you can see some of the statistics. This is President Trump's Surgeon General, Jerome Adams. And you can see African Americans by percentage of population and share of coronavirus deaths. Chicago, Milwaukee, Louisiana, Michigan, New York City, much higher rates. And when this took off in March, the COVID-19 deaths, very quickly this disparity opened up. And it's the disparity that has existed for decades, and even longer, for over a century. Racial disparities in health in terms of life expectancy, infant mortality, maternal mortality, healthcare spending, you name it, and not in every area, but in the majority of indicators and measures of healthcare and well-being and spending, there are disparities across the board based on race. Just another slide that just shows all the different disparities in different states and cities based on race. So if you've been studying healthcare for a while, racial health disparities is just another category that you're very familiar with, along with geographic disparities and socioeconomic disparities and ethnic disparities, and sometimes gender disparities. Disparities are just a huge thing you become very familiar with. But that's for people who work in healthcare and study it all the time. The general public seeing this data, I think many of them are just really shocked that there's this level of disparity, variation, and whom COVID-19 has had the biggest impact on, and who it's devastated the most. This is an article in the Wall Street Journal I encourage you to click on. It walks through the structural and institutional reasons that communities of color and people of color, why they're more vulnerable to, and why they're being hit more profoundly and devastatingly by COVID-19. Again, things I've mentioned previously. People who have jobs that they cannot do from home, jobs that are now being deemed essential, because they are essential in the sense that they keep transportation, package delivery, and food production, and energy production, the things that we really are depending on dramatically to keep semblance of normalcy going. Well, it's not like a cross-section of the United States works in that and staffs those positions. So that's a huge contributing factor. Another contributing factor is that people of color as groups tend to have higher rates of chronic diseases for all the reasons you read about. Higher rates of trauma, less access to gainful employment, higher levels of stress throughout their lives. All of that is just coming along, and it gets intersected by COVID-19. And it's a perfect storm for people who are more vulnerable and whose underlying overall health is less. And you watch the TED Talk by Dr. Nadine Burke Harris on adverse childhood experiences and childhood trauma and toxic stress, and a strong correlates between the number of those events in childhood and the likelihood of all kinds of diseases and maladies and conditions later in life. And a very, very strong connection between the levels of chronic stress and trauma in childhood and someone's susceptibility to heart disease, to cancer, to mental health issues, depression, suicidality. It'll force you to come to grips with the things that are harder to see. It's the structural, institutional differences in access to resources, differences in access to opportunities, differences in the way people are treated. And once you come to be familiar with that data, as she says, the single most important thing we need today is the courage to look this problem in the face and say, this is real and this is all of us. Interestingly, she's the first Surgeon General of California, so she is now toggling back and forth between being a clinician and trying to take some of that informed, data-driven insight into disparities later in life and work at the policy level. And I think it's a great opportunity for people who are on the front lines medically and clinically and see this stuff over and over again to then inform macro level policies where hopefully you can achieve some addressing of these imbalances. You can do it, shift your mentality to being upstream. So instead of just trying to diagnose the immediate condition and then try to fix that by a pharmaceutical or intervention, just to ask different questions of your patients and say, you know, what is your home life? What is your home conditions like? What is your physical, social environment like? Knowing that in many instances, that might, the example he uses of that what might be distressing this person physically might be allergies or asthma, and those might be triggered by the quality of the air in their apartments or their homes. And so just treating downstream the symptoms is not going to solve them. You have to go upstream to the thing that causes it. Once you get exposed to this, you can apply upstream thinking to all areas of life. Think of university life and college life. When students get to a point of being physically ill or mentally distressed, you can't just deal with that issue at the moment and try to remedy it, put a Band-Aid on it, get them through, get them home, get them the semester, do an immediate fix of the severity. But if you do that enough, you're tempted then to say, well, what's the pattern here? Is it you know, where upstream can we intervene on number of courses you're enrolled in, or how much financial aid you took out, or how many jobs you're working? Do you live in a single? Do you live in a double? What is your dorm condition like? And that's far more engaging, because if you can intervene up there and prevent these things or solve them up there, that's a much greater solution. But we're also interested in, this has always been a problem. Sometimes the patients have been mistreated. Sometimes the clinicians face institutional and individual forms of racism. We're seeing this really interestingly now in several cities where patients refuse care by Asian clinicians. And they're fighting their own forms of racism because the people are not logical or rational, but they're very, very upset about the idea that this is something that China has inflicted or that Asians are responsible. And you can just read these accounts of Asian clinicians trying to figure out how in the moment you handle someone saying something horrible about you or striking out at you, blaming you for something at the same time, the very moment you are trying to help that person. We can talk about this at the macro level. This plays out at the micro level, and it takes a toll on clinicians who themselves would just ideally like to be home in a safer position. I mean, there's a lot of irony in this, that the people who are literally on the front lines and sacrificing their own safety are the ones, if they're Asian in this situation, are the ones facing this discrimination and racism. You can read this. I'm not going to read these words out loud, but it's stressful enough to be in places where you're exposed to COVID-19. On top of that, to not have gratitude by the patients you're trying to help, but to have anger and enmity directed at you. It takes a toll. It definitely takes a toll. And all your credentials and all your training and all your expertise, which patients need, won't always protect you from that. This is a famous article in the New England Journal of Medicine about how to handle those situations, because you might think you would respond on the spot when it comes out of nowhere. You might handle it very nimbly and very professionally, but what often happens in life when people all of a sudden strike out at you, maybe not physically, but when they verbally accuse you or verbally attack you, what's interesting for most people is you tend to freeze, and your mind just goes blank, and you start to think, did I say something? Did I do something? You almost kind of, in a sense, scrutinize yourself first, and did I do, what would have possibly engendered that? And this is just a better way than to try to think you're going to be that quick on your feet, is to have protocols in place and to be sort of prepared, for, like, for instance, if patients say, I don't want to have care, like in these cases right here, the patients were saying, I don't want to be treated by Asian clinicians. How do you handle that as an individual, as a hospital, as a health system? Because it's a very high principle, sacred principle in medicine, that patients can refuse care, and patients can request and accept, in the end, the care that they choose. The patient autonomy is a very important principle. That's an important principle. On the other hand, another important principle is a workplace environment that is free of discrimination and racism. So how do you reconcile that? Well, this decision tree, protocol tree, is an attempt to sort of say, if that happens, assess the medical condition. Is the patient unstable? Is the patient stable? If the person's unstable, you just treat them because they're not in good shape. If they're stable, like in the instances that I showed you in the slides before, then you have to kind of go down to another level. You have to assess their decision-making capacity. Do they have decision-making capacity, or do they lack it for any reason? If they have it, then try to determine a reason for the request. If it's bigotry, then go through these different options. If it's clinically and ethically appropriate, it might, it could be a case where a woman needs to have a gynecological exam and they don't want a male, or for religious, personal, and philosophical reasons, will then accommodate. But if it doesn't fit into those categories, this is where it gets tough. Trying to figure out this balance of allowing patients to choose care as autonomous patients, but not to allow bigotry and racism in the health system, right? And then if you don't allow that, if you don't permit them to make that kind of decision, then you have to come to the position of saying, well, you might have to ask them to leave or force them to leave. Or another bad option is to force a clinician to go in and treat a patient who is being racist and bigoted towards them, which is going to cause trauma to the clinician. You'd think this was a rare thing, and unfortunately, there's an article about it, and if you interview clinicians, it's not as rare as moment-like. The last thing that we covered for today's class is this fascinating paradox, the healthy immigrant paradox, where immigrants who first come to the United States tend to have some of the highest health statistics. And then, interestingly enough, over time, the longer they stay here, the more their overall health deteriorates. In other words, the more they adapt themselves and accommodate and integrate themselves to the American lifestyle, the more their overall health deteriorates. And the documentary does a really good job of going through different hypotheses about why is the health of low-income immigrants who are often working tougher jobs, why is their overall health so good when they first arrive? And again, it might be because they're the healthiest who could immigrate. But as you saw in the documentary, one of the key factors they think is really determinative is strong family environments, supportive networks, people that are around you that cushion the blows and the challenges and the stress. And this goes back, so it's like an upstream intervention of a protective social network and family environment that clearly helps people manage stress. Conversely, you can see why the more isolated people become, and maybe that's actually part of the American condition, is that we have such an individual orientation and an individual mind frame and individual rights and liberties, that isolation is is when you lose a lot of that protective barrier. If you don't have someone you can talk to on a regular basis, if you don't have someone that can shoulder and manage the stress of managing the finances of a household and transportation, then you're losing this sort of protective bubble around you that that many immigrants have when they come with their families. That you look at their situation, you think, oh my gosh, their health must be really compromised. And then interestingly, no, it isn't initially. It's just as they get more accustomed to the American lifestyle, which maybe says more about the American lifestyle than anything else. Okay, that is a quick overview of all the readings. I look forward to reading the papers, and I will see you again.
You have stopped screen share
Soon. Take care.